everyone. For those of you who don't know me, my name is Barbara Weiss. I'm a nurse practitioner who originally worked for I&I Neurology and worked with the Tele-Neuro-Hospitalist program. I have a long history of neurology practice, whether it be as an RN at the bedside or as an APN. And I still do honestly work PRN for I&I Neurology in that capacity here at St. Joe's. The reason I come to you today is because I'm currently working on my DNP project, and I'm asking for all of your help with my quality improvement project to, benefit the stroke patient, but also benefit your practice. So I do have a favor to ask that everybody fill out my survey. It's just a general survey about performing bedside assessment, how well you understand the NIH, how confident you feel doing an NIH or a neurological assessment. For those of you who are viewing this via video, my little survey will actually be in Ashley's box in a envelope marked stroke survey for you to fill out prior to viewing this presentation. So the National Institute of Health Stroke Scale is an assessment tool used on all stroke patients. That's ischemic stroke, hemorrhagic strokes, and TIA patients upon admission and throughout their hospitalization here at St. Joseph Medical Center. It is part of the order set that all stroke patients receive an NIH assessment per shift. And it's also part of our guidelines that we follow, that they have a NIH prior to discharge as well. So my goals today and my objectives are to explain why the NIH is performed, how the NIH is performed, relate the NIH assessment actually to the brain function, and help you understand the benefits of a good neurological assessment, the importance of a baseline assessment, and relate the NIH to your patient's neurological outcomes. So the NIH score is important for many reasons. It helps us determine the course of a patient's treatment when they arrive down in the emergency room. It also helps us determine whether or not they can qualify for intervention. If they don't qualify for intervention, it helps us determine how severe the stroke is. It allows healthcare professionals to understand where your patient deficits are, and also helps you identify new neurological dysfunction in case they're extending their stroke. So the basic rules in performing an NIH stroke scale is to administer it in order 1 through 11. Score only what you see, not what you think you see, because you want to give a true score and not kind of fudge the score so that the patient is doing better than what it looks like. You want to minimize coaching the patient. You only want to score their first attempt. And then there are some alternative techniques that may be used to elicit a response from a patient, and we'll go over those in each individual section. Okay, so the NIH stroke scale can be related back to each section of the brain. For example, your speech centers are in the left portion of your brain and are known as the Wernicke and the Broca areas. So if your patient's having a difficulty with their speech, you can determine just basically by doing an NIH stroke scale where that brain function comes from. So I'm going to pause here for a minute before we start on the NIH stroke scale and just go over a couple of other things here in your packet. Part of my process improvement is going to be that I ask each and every nurse to identify if they have a stroke patient at the beginning of their shift. And if they have a stroke patient, I'm going to ask that you and the off-going nurse perform a brief assessment using assessment tools out of the NIH to assess your patient and establish a baseline. Establishing this baseline assessment as you are coming on is going to do several things for you and several things for your patient. So what it's going to do for you is it's going to allow you to know where your patient's at right at that moment, and you're going to be able to have an agreement with the off-going nurse that this is the baseline of the patient. The other thing it's going to allow you to do is it's going to allow you to pick up on any change in your patient's neurological assessment or decline, or even improvement in their neurological assessment as you do your follow-up assessments throughout the day. It's also going to help you, if you do find a change that needs to be reported to the physician, it's going to help you verbalize what assessment is declining, which is going to help the physician determine if the patient qualifies for any further intervention or treatments based on your report. So what it does for the patient is early intervention with a stroke in a patient that is declining can actually save some brain tissue. So anytime a patient has a stroke, what we look at is that you have a core in the middle of that stroke center, okay? But there's an area around that core known as the penumbra, okay? And that penumbra is tissue that may have some reduced blood flow, but still has some good blood flow that it is being perfused by. This increase, our goal is always to ensure that that penumbra area maintains its blood flow. If that penumbra doesn't maintain blood flow, then what happens is we start to extend and expand that stroke, so we have more and more dead tissue. So what we want to do is maintain that penumbra with typically a higher blood pressure, okay, and higher perfusion rate, and that can be by having your patient on fluids, making sure that they're not taking unnecessary blood pressure medications that would reduce this pressure that we're trying to keep and save this penumbra area. So that's why the first 48 hours of a stroke patient's stay here at St. Joseph Medical Center is very important, because we're trying to stabilize that blood flow to that penumbra area. So that's what we're looking to achieve with these neurological assessments and close follow-ups and agreement between two nurses about where your patient is at shift change. So you'll also find in the packet that there is an algorithm for, you have a stroke patient, you identify that they're a stroke patient, you perform a bedside assessment, and as you go through the day, you do your follow-up assessments. If you find a change, then you would, of course, notify the hospitalist and follow whatever they request of you to do, whether that be give some fluids, take them down to a head CT, something of that nature. So we'll go ahead and go on with the NIH. So the very first section of the NIH is actually number 1, but it's broke down into 3 sections, okay? So it's 1A, B, and C, okay? So really, level 1, level of consciousness is just how alert is your patient when you come in the room. Are they bright-eyed and they notice that you came right in the room? Are they a little sluggish? They don't quite notice you when you first come in the room. It requires a little bit maybe of minor stimulation, talking to them, something like that. Or then a 2 would require some repetitive, hey, Mr. Smith, wake up, would be a 2, and then a completely non-responsive patient would obviously be a 3. So the level of consciousness 1B is you're going to ask your patient 2 questions. Now this needs to be the same 2 questions, and if you actually look at the NIH scale that I've given you in your packet, it will state that you want to ask them only what month it is currently and then what is their age. And we do this in this section to ensure that the nurses are asking the same question over and over again and grading on the same questions each and every time. You're welcome to ask any other time, who's the president, where are you at right now, and all of our other level of consciousness for your assessment. But when you're grading the NIH, those are the only 2 questions we want you to use, okay? So it's really simple. If they get them both correct, then they get 0 points. Just 1 correct, they only get 1, and then none correct, they get a score of 2. So then the last one is you ask them to perform a task for you. So this task can be close your hand, open your hand. This can be show me thumbs up. There's no mandatory 1-step question that you ask in this section. So you can, be creative if you want, have them, smile at this time. That's a 1-step command, okay? And they need to follow it. You can give them a minute or 2, especially if you just woke them up, but you want them to follow your 1-step command fairly quickly. So again, if they can perform both tasks, they get a 0. They only perform 1 task, they get a 1. No task, they get a 2. So, best visual gaze is performed just by doing horizontal evaluation only. So you'll ask them to follow your fingers, you'll go across the horizon, you'll watch them as it comes across, and you don't want to do this quickly, you kind of want to do it at a nice steady slow pace going both ways, okay? And what you're looking for is that they follow all the way across. Now if you have a person who can't come across the horizon, you might have one eye or both eyes that have a slight deviation, but they can bring it up to midline. That would be a patient that would get a 1. Of course, if they do it completely, that would be the 0. A patient with what we call forced deviation or total gaze palsy is not even able to come out of that deviated gaze. So they're not able to come up to midline, they're not able to even move those eyes across the horizon. If for some reason you would have a patient who is not able to follow commands, you can achieve this evaluation by doing the oculocephalic maneuver, also known as the doll's eyes maneuver. And what you would do is you take their head and quickly kind of jerk it to see if the eyes can be forced out of that gaze palsy that you see. Another thing, let's say you're having somebody that's having communication issues, something that is recommended is if they're not following commands, you can move about the room and watch them, watch their eyes as you walk about the room and see if they follow you walking about the room. If they are able to do that, you're able to give the person a 0, okay? And again, if they can come up out of that gaze a little bit, then they get a 1. If they cannot come out of that forced deviation, then that is a 2 in the best gaze. So, here's an example of oculocephalic maneuver. You can honestly just Google how to do this and what is correct. But the easiest way I tell people is that, you know, when you do this shaking of the head, you want to see the eyes kind of move and roll. And the reason I call it, or the reason I say doll's eyes in this particular section, is if you took a Barbie doll and you laid her on her side, or you moved her head around, her eyes don't move. They stay in that gaze, okay? So that's another way to think of why it's called doll's eyes. But there are several precautions we would want you to do, and that was definitely make sure your patient doesn't have spinal issues, especially in the cervical spine, before you would attempt to do this. So it is a good way to assess a patient that might not be so conscious. So then the visual section is tested. Technically, in each quadrant, we would want you to test each eye independently. So you ask the patient to cover their eye, or you cover it for them, and then you want to test each quadrant of that eye, and same thing over here, each quadrant. Now the way I typically test it, if you got somebody who's communicating really well with you, I do a 1, a 2, 3s are sometimes hard to see when you're doing the quadrant testing. Another way to do it is if you're having somebody to have verbal speech and they only say like yes, no, things like that. I have them say either now or yes when my finger is wiggling in each quadrant. Now if you have somebody who says, oh, I don't see your finger at all, obviously you have a visual field cut in this quadrant, okay? Or here, and they say, I don't see anything here or here, you have a visual field cut in this quadrant. You do the same thing on both eyes and kind of add up each quadrant and the pattern that you find with that. So no visual loss in any of your quadrants. You would give them a 0, a partial hemianopia, and that's even just one quadrant gets a 1. A complete hemianopia, which would be 2 quadrants, or a half would be a 2. Bilateral hemianopia, so that's 2 halves, or complete blindness gets a 3, okay? So, this is one of the sections where I say that you only judge what you see, and even if they had blindness from birth, you would still give them the 3, but I always encourage nursing staff that when they're putting that into Epic, there's always an area you can make a note that says, you know, you can put in blind since birth, things of that nature. Another way of assessing visual fields on a patient is, especially in somebody who is not as communicable, is to do a visual threat. So usually what I would do is cover their eye and dart in from each quadrant to kind of see if they blink, okay? It's the blinking action you're looking for when you're using a visual threat to kind of evaluate the quadrants on vision. And then of course, you know, vision has long tracks through our head that start all the way at the back of the brain and manifest in various quadrantinopias and hemianopias. If, let's say, there was a lesion here at number 4, you'd have that hemianopia there and so on. So you can, you know, based on what your visual field cut is, you can pull up a chart similar to this and figure out what section of that visual field track is actually being impacted by your stroke. So the next point is facial palsy. This is number 4. You're actually looking for that facial droop, the downturned corner, the inability to pull up and make wrinkles. A lot of us older people have these crow's feet here. And then also not able to kind of raise up their eyebrows. So this is why in this section we ask you to smile and show your teeth. Shut your eyes really tight because you're shutting them really tight, and opening them really wide. This gives you the ability to say, you know, they had full movement in that area. I don't see a facial droop. Minor facial droop, that's usually the flattened nasolabial fold or the downturn of the outside corner. Partial paralysis, usually I say, is here and here. When you come up with your crow's feet a little bit, you know, you have an expanded inability to move. And then complete paralysis is the complete portion of the face, including some of that upper area. So our next, let me just back up one thing. On facial palsy, if you need to assess it, you can do a little bit of painful stimuli to see if they grimace. That's not what we always like to do, but if it's necessary for you to give a little nail bed pressure or something like that to get them to give us a little bit of grimace, you can assess those facial structures that way as well. So motor function is tested really easy. Now I know you will see a lot of times the APNs or the physicians walk in and, you know, ask the patients to hold their arms up like this, and they'll count. But when you're doing the NIH scale, we actually ask that you perform this independently on each side. So what you want to do is you want to typically have the patient raise their arm if they can. If not, you assist them to bring it up into the ear. And then tell them what we're going to do prior and tell them we're going to count to 10 and I want you to hold your arm, do the best you can to hold that arm up in the air for as long as you can. So you bring the extremity up into the air and you say, and I usually count out loud with them seeing 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. And you do this for both sides. So obviously if they do a really good job, they hold it up there. They may have a little bit of a bobble if you were assisting them to get into that position. But they hold it, it doesn't really drift down, that's a 0 obviously. A little bit of a drift, a little bit of an extra muscle tension in it is typically a 1. A 2 is they have pretty good effort against gravity, but they usually do have a more significant drop, and it usually drifts down to the bed, but they're, you know, struggling really hard to keep it off the bed. That's typically a 2. They usually do pretty well keep it off the bed for the full 10. And then a 3 and a 4. This is usually tough for people, but 3s and 4s hit the bed really quickly, okay? The difference between a 3 and a 4 is the fact that you're able to make some muscle tension gives you the 3. So, you know, they're able to move their thumb, give some shoulder shrug, you see some tension in this upper muscle. If you give some painful stimulus in the finger and they contract a little bit, you would be able to count that as a 3 instead of the complete 4. So, and that's done for both arms and scored exactly the same way. And then for the legs are done independently. I have had patients try to hold both legs at the same time. So just explain that I'm just going to have you hold up one leg. This is only for a count of 5, okay? And I usually do position their leg where I want them to hold it. I don't, you know, get it too far off the bed, but you want it a good 12 to 20 inches off the bed or so. Tell them you're going to let go, and then again count out loud. 1, 2, 3, 4, 5. And again, assess it the exact same way. Doesn't fall at all, that's a 0. A little bit of drift, but does not go down to hit the bed, that's a 1. Some drift, gets down to the bed at 5 seconds, maybe hits it at the count of 10, that's your 2, and then 3 or 4 is pretty well hits the bed all of a sudden, but this person's able to give you some muscle tension somewhere in that leg. Withdraw a little bit if you need to from painful stimulus. You can give that 3 for that section. So we probably already all have seen this in school where you can trace back those motor functions of the body to these locations on the outer portion of the motor cortex. Other sections that impact the motor ability, which is what we see a lot in our stroke patients, are also the tracts that allow that motor cortex to connect to the brainstem area. So you have the thalamus and so on and so forth. So sometimes you can get different motor symptoms based on the track it is taking through the brain. So a lot of times if you read your CT report or your MRI report, you'll see ischemic stroke signs in the thalamus, or the putnam or something of that nature. So this will give you a good idea of where that is located on those tracks on their way out of the brainstem into the body to make those connections. So the next section, yes, is ataxia. Ataxia is kind of my pet peeve because I usually find this one scored. And we test this one by doing finger, nose, finger with the patient, and we also test it by doing a heel shin test where you have them take their heel and rub it up and down their shin. So you ask the patient to perform the finger, nose, finger and the heel shin test. On finger, nose, finger, they're going to miss their face, miss their nose. They'll be touching their face. They'll be missing your finger significantly when you're asking them to do this. On the shin test, those patients that test positive will kind of snake down the leg. They won't perform a straight line when they do the heel shin test, okay? So if they do this on both sides perfectly, obviously that's the 0. Present in one limb, it's the 1, and present in 2 limbs, it's a 2. If they have an amputation, obviously you can mark amputation as well. But what I want you to understand, in this section, you can only give a score, and this is the one place we get to give them credit, you can only give a score of ataxia if the limb is able to move. So let's say I come in with a stroke and I am flaccid all on my right side, and I'm not able to do the finger, nose, finger, or I'm not able to do the heel shin test. This limb and this limb do not count as 1 and 2. It's only this side we are going to score. We're only going to do finger, nose, finger here, and if they do it just fine, that is a 0. And if they do it just fine in the lower extremity, that is also a 0. So that patient would not get any marks here, not get any marks here, so they would be absent. So let's say I come in with the complete right-sided flaccid again, and I'm all over the place. I can't do it in my upper extremity, but I can do it in my lower extremity. That patient would be a 1 because it's present in 1 limb. Of course, if I did it in 2 limbs, then it'd be present in 2 limbs. If you actually look at your NIH stroke scale in number 7, it actually clearly states that, I think I actually put it on here. Oh, what section are we actually scoring? We're actually scoring the cerebellar area. But it says, ataxia is absent in a patient who cannot understand or is paralyzed. So if you have a patient and they're not understanding you and you're not communicating with them well enough, you still get to give them a 0 on ataxia. Okay, this is the only place in the whole NIH we get to give them credit, so to speak. So, and we're looking at that cerebellar area with this, because we already graded motor function on the 2 before. So we're looking for coordination, we're looking for fluidity of movement in this section, not necessarily are you able to perform a motor function. We've looked at that. So, and feel free to shoot me an email if you don't understand that. I will be happy to come and talk to you about it, demonstrate it for you, and so on. So then we move on to sensory. Typically I for sensory, stay away from hands and feet. You should actually be getting a safety pin from the nurse's station desk. We don't have to draw blood with these, they're just for the sharpness of it. But you want to test, typically I test both sides upper arm. I usually do a little bit of the trunk, and I do upper legs. I also do bilateral face and bilateral top of the head. So usually I work all my way down. And you're going to ask the patient, does it feel the same on this side as it does on this side? And if they say yes, that's a 0. And that's all the way down, obviously. If you find that you touch them with the safety pin in various areas on your way down the body, and they say, oh, hey, that's a little bit different. It's a little duller on this side. I don't feel it as much on that side. That patient is a 1, okay? And again, you go down, and if they have no sensation, they don't even recognize they're being poked with a pin somewhere down this section, then that would be your patients, the 2. The reason I stay away from hands and feet is because in our older population, you have a lot of neuropathies out there, and that can give you a false reading if you use your hands or your fingers or so on. So it's best to kind of stay in the upper arm and upper leg areas. So again, you can map this out just like you can with motor function, with various sensations along the sensory cortex, which is just basically like a headband right behind your ear area, as you can see here. They do run those same tracks through down to the brainstem, so that you get that stimulation from the body, and it comes up and registers. So if you do have a stroke out in this section, it can impact something here, or even up here, because it runs through that track down to the brainstem. So, but it can be just, if it's just small area, sometimes it's up in this area as well. So sensory deficits need to be evaluated very carefully, like I said, with the safety pin. And these are some of those areas that those tracks can go through: the hypothalamus, the thalamus, kind of the pituitary area to get to the brainstem to then come out to the body. So best language is our next section, and that is scored by using our naming cards. So you're going to ask the patient to look at this picture of the lady doing dishes and the children getting in the cookie jar, and the water flowing over and the little girl laughing and so on. So you want them to articulate and tell you what's going on in this picture. So you want them to tell you that they recognize that the water's coming out of the sink, that the child is falling. You want them to recognize the danger of what's going on in this picture. I've had people tell me about what's going on outside the window, all sorts of silly things, but and then typically you also want to have them look at this one and name several things off of this sheet: chair. I've had people call these plants instead of cactus. I actually do count that. If you have somebody, let's say they don't have their glasses, they are having a hard time seeing this, you can use everyday objects such as ink pens, keys, quarters, things that they can recognize. They just need to be able to tell you that's a quarter, that's a key, so on and so forth. So I did have one person tell me that we need to update our key one time. So another thing you're going to have them do is you're going to have them read these sentences, how, down to earth. I got home from work, near the table in the dining room. I heard him speak on the radio last night. And so what you're looking for in these sections is some fluidity and their ability to read the sentence, say the sentence. It's rare I find anybody anymore who can't read. In my history in being a neuro nurse on the floor, I did run into a few people that couldn't read. So what we had to do is I'd read it to them, they'd regurgitate it back to me, and that worked rather well. And that's very rare anymore that I have to do that. Another thing I have also done is somebody who doesn't have their glasses, I'll go to the copy machine and I'll actually blow these up really, really big if they are having visual trouble seeing these items, and see if I can get them to tell me. So then this section is scored if they do fine on all of those pictures, they have no aphasia. Somebody who has some difficulty, whether recognizing something going on in the picture, they have some loss of fluidity in those sentences, they're not able to name all, they're not able to name some of those items, they get stuck on them, they say the wrong thing, they say, they say bird instead of cactus or something like that. That's your person that's kind of just a few glitches here and there is your one. Somebody who has pretty severe, they have more of a fragmented speech, kind of like I'm doing now, no, easy. And they just don't get everything right. They miss a lot of the naming things, they don't read the sentences very well, they don't identify the what's going on in the pictures very well. So that's your two. And then somebody who doesn't speak at all or only makes kind of grunting sounds, and those are your patients that are mute and are what we call globally aphasic. Oh, so I do have pictures here. So you have your expressive aphasia, which is your Broca's aphasia. This is a deficit with your ability to get your speech out. Then you have your Wernicke's aphasia, and that's the ability to understand commands in what's coming in. And then your global aphasia is total loss of the ability to communicate. And those do correspond with a section in your brain, and I'll just illustrate that here. Your speech centers, Broca and Wernicke's. And so if you find somebody with these two particular deficits, you can go, aha, I know where that's located. That's on the left side of the brain for most people. So then dysarthria. Dysarthria is more of a slurred speech, where you have, many times people with dysarthria will also have a structural issue, maybe some facial droop that causes them to slur a little bit. Or something of that nature. So you ask your patient for this particular session to say the list of words, which I think I have here. Mama, Tip Top, 50/50, Thanks, and Huckleberry. That is in your packet on NIH. What you're looking for is, is there slurring of those words, or can you completely understand what they're saying? 50/50 is very hard for people. The Huckleberry is also pretty hard, and so those are the easy ones to pick up if there is any slurring of the speech. We'll go back here. And so then, obviously they get a normal for saying all the words completely normal. You pick up on a little bit of the slur. They get a 1. Severe dysarthria, you almost can't understand what they're saying because it is so slurred, would be your 2. Unable to assess is usually due to intubation or some type of physical barrier at their mouth. Okay, so extinction or inattention. This is number 11. This is our final point of the NIHSS. It is actually tested in several ways. You sometimes will pick up on the severe inattention, inattention or extinction. This was formerly known as neglect, and I still want to call it neglect because that's how old I am. But anyway, so this is tested by visually assessing whether or not they can see on both sides. I'm going to put this down here. So typically what I tell the patient, and I sometimes will do this back in the vision, is I'll ask them, tell me which side you see my fingers wiggling, and the correct response is either right, left, or both. I usually use their right, their left, obviously both. And so I'll wiggle my fingers and they'll tell me which side. And what you're wanting to establish here is they see you on the right side and they see you on the left side. But the key of what you're grading is, do they see it when you wiggle both fingers? Wiggling both fingers tells you that they're taking information in on both sides of the body. And they're able to process it in their brain and then able to tell you that both sides are actually wiggling. Tactile. Tactile is done the same way. I usually have them shut their eyes. Am I touching right, left, or both? Again, you touch one side and establish that they have sensation and they can feel you there. If you already found a sensory deficit, sometimes I'll touch that side a little bit firmer. But again, what you're really grading is, do you feel me touching you on both sides? Are you able to process that and understand that you're being touched on two sides? Auditory, sometimes you can do that by talking to somebody on one side and talking to them on the other, and then talking right in front of them. You'll pick up on an auditory real quick because these are the patients with an auditory deficit that you talk to them from this side of the bed and they act like you're not even there. They don't even hear you. You walk to the other side of the bed and you talk to them and they're like, oh, hi, nice to see you. Spatial can be small spatial. These two are really kind of harder to test. The spatial people are going to be, I ordered milk or I ordered coffee with my breakfast and they didn't send up the coffee. And you go, oh yeah, honey, the coffee's right here. And you move it into that section that they are taking up information from, and they're going, oh, I didn't see my coffee. That's because they're kind of neglecting or not paying attention because the brain's not allowing them to pay attention to that side of their plate, okay? So if you pick up on one or more of these, and it's a very slight one, you can give them a 1. The patient with profound inattention or profound neglect is a patient that completely loses that half of their body. I've seen this many times in my practice where you can actually take that patient's hand and place it in front of their face and they have no idea that it's their own hand. That's how much they've lost. They've lost 1/2 of their world. Those are harder to find, but I have seen them. Usually it's these small inattentions or neglect that you will pick up on. But again, visual is easy to test because you just establish for both sides, and tactile is easy to test because you just establish they feel it on both sides at the same time. So, okay, so that's the NIH and the assessment pieces for that. So again, the importance of doing a bedside report, and this is what I'm going to ask you to do starting on January 7th, is that when the oncoming nurse comes in, that you go to the bedside, you perform your bedside report, that you do a brief assessment using the key assessment pieces from the NIH to establish your patient's baseline. This, allows you to agree with that oncoming nurse. And for example, let's say the offgoing nurse scored a 3 for that patient all night long, but then you come in and you didn't do bedside report with them, and you find that NIH is an actual 9. You then aren't sure if this is new for the patient, not new for the patient. This is actually going to help protect you because when you have to call that hospitalist and say, hey, they're now a 9, you don't have to, you can say, oh yeah, but we agreed at shift change this was the patient's baseline. So real quick, and true story is that when I was an APN here, I I came in to see the patient, asked the oncoming nurse what the patient's assessment was like, because I had found a significant change in the patient. It was like 9:30 in the day. She hadn't assessed the patient that day, and the patient happened to be a TIA patient who had gone back to zero, a baseline of 0, but I found him at like a 5 or a 6. And I actually had to call the night shift nurse to establish when that patient was last known well so I could give the patient TPA. Now, we did give the patient TPA, but it was really difficult because that nurse who came on for the day shift had no idea what her patient's baseline was, and we could have administered TPA much quicker had she gone to the bedside and said, "This is my patient's deficits, and I know what they are right now at 7:30 in the day." And another bonus to doing this brief bedside assessment is that you have your first neurological assessment out of the way, and you can document that at your upcoming assessment required, I believe, possibly at 8 o'clock in the morning. So it's going to help you understand if your patient has a change throughout the day, or even a positive change. Yes, we're looking for the negative changes because that's what we're worried about during their hospitalization. But you can assess your patient and understand that they may need your help a little bit more than just letting that penumbra grow, because there are things that the hospitalists can do to help save that penumbra. Sometimes it's as easy as giving them a little bit of a fluid bolus so it beefs up their blood pressure. So I will be sending out more information about my stroke intervention and my quality improvement process. But this is my algorithm that talks about, you get a patient to the orthoneural floor, you do a brief bedside assessment, you do your assessments throughout the day, and record your findings in the electronic medical record, EPIC. And if you do find a change, that you notify the hospitalist. If you do find a change, I'm also going to ask that you fill out a questionnaire that's going to be kept in the charge nurse book. I'm going to ask that if the charge nurses get a change reported to them, that you fill out this questionnaire. And it really is just kind of tracking the numbers for me for my quality improvement project. It will just ask you, like, what was their NIH when you came on to shift? What is their NIH now? Was the hospitalist or neurologist notified? And was there any intervention? I do have on that particular piece of paperwork the patient's MRN, but all of those MRNs, and it also asks for the nurse's name, all the MRNs and all the nurses' names will be taken away prior to evaluation for the study that I'm looking at. So also at the beginning of the shift, here's actually that sheet. I forgot I put it in here. So it just asks, is it a male or female? How old are they? Did they come in with an ischemic stroke or a TIA? And so on and so forth. So this will be what's living in that charge nurse's book for you to briefly fill out, quickly fill out, and put back into the charge nurse's book for pickup, so we can evaluate this process. So, and again, this is how it impacts the patients. If you find that neurological change, you notify the hospitalist. And you can make a difference in your patient's outcomes by doing the bedside report and your follow-up assessments, and establishing that baseline assessment is important for you and your patient. The end. I would also ask that you fill out my little questionnaire about how how comfortable you are with NIH, and it does ask that you put your name up here. You can put your employee number. You can even put an alias like Little Bo Peep. I don't care what name you use, as long as in 2 months when we finish this study, I'll have you fill this out again, and that you would use the same name so I could pair them up to see that you had an improvement or you had a better understanding by this process of having this presentation. I'm also going to be coming around to the floor, talking to nurses, helping them understand the NIH, so you will see me not just here, and I want to come around and make sure everybody doesn't have any questions, and that you truly do understand what the project is and what the NIH really is going to, how it's going to help your patient and impact your patient. So feel free to shoot me any questions via email. I will be sending this all out on email, and just use that email. It's Barbara L. Weiss at OSF. I do currently still work for OSF. So I hope you enjoyed this presentation, and please feel free to shoot me any questions.